Have a roundtable discussion from the committee chairs, one for research, John Nachega. Student exchange is Faith Nawaji. Education is Judy Hanyola. They will introduce themselves as they give the roundtable discussion so that I don't take a lot of time. We'll get into breakout sessions for 20 minutes in each of these groups and have a short discussion, and then those discussions will be moderated by the different chairs of the committees, and then we get back to get some feedback from the groups. Then we'll have closing remarks from Quentin and myself, and that should take care of the few minutes or 1 hour and a half that we have together, 2 hours that we have together. Thank you very much for coming. And now I'd like to call upon Professor Abigail Kazembe, the AFREhealth Vice President and also co-chair of this important working group, to give us a welcome and some opening remarks. Abigail, over to you.
Good morning, good evening. Thank you so much, Elsie. I'm delighted to open this session as we have been learning about AFREhealth, its activities, partners. We continue to do so this evening or afternoon, morning, sharing with Consortium of Universities for Global Health as working groups. CUGH is our long-time big brother. We started together and has done a lot of work with AFREhealth, including mentoring young organizations such as ours. And we really value our relationship. And between the two working groups, we do have subcommittees that look into research, education, and student affairs. These are key to AFREhealth as we are dealing with the interprofessional education research that will form also service delivery. And we feel honored to work in partnership with the CUGH because it has contributed towards the growth of AFREhealth in our core business. As we continue our journey, I just want to recognize our partners from CUGH. As Elsie has indicated, I co-chair this committee with the Professor Quentin Ekbam. And as she has rightly said, I am a nurse midwife by profession, working at Kamuzu College of Nursing, now Kamuzu University of Health Sciences in Malawi, and I'm based in the midwifery department, where I'm an associate professor. And working with AFREhealth has been a pleasure for me, and I am now the current president, and feel, a pleasure to welcome you all to this session. And as she has rightly said, we have a lot of discussions surrounding research, education, and student affairs. At this point in time, I don't want to take much of your time. I just want to invite my co-chair, Quentin, who is from CUGH, to briefly talk about our committee. Thank you.
Hello, everyone. I hope you can see and hear me. My name is Quentin Eichbaum. I am the co-chair of the AFREhealth-CUGH working group, and I was asked to put it in context, say a few words about how it was formed, and for those of you who don't know much about CUGH, say a little bit about that. And I wanted to thank Elsie for putting this satellite together at breakneck speed. I did it at the CUGH conference, and she, despite a very busy involvement in a very reasonable attendance, even though this is the last session of the day. Can you see I think my slides were up and then I lost them, but let me try again. Can you see them now?
We can see them.
Yes,
okay, good. All right. So yeah, just a bit about CUGH. It was founded in 2008 with seed funding from the Gates Foundation and the Rockefeller Foundation. It was amalgamated with a group called GHEC, which was founded in the 1990s. And I remember as a student even attending a GHEC meeting. Secretariat was opened in Washington in 2012, and it's currently, I think, still the largest academic global health organization in the world, with I think almost now 180 academic institutions, associations, and NGOs as partners, and a network of probably 30,000 on the network. The mission of the organization is to support academic institutions and partners to improve the health of people and the planet across research, education, service, and advocacy. So that's some very broad sweeps what CUGH is about. The group is comprised of a lot of major committees, the advocacy committee, there's a board of directors, I sit on the board of directors, and there's an education committee I used to chair with 8 subcommittees and working groups, research committee, operations, executive committee, finance committee, membership committee, and then there are various working groups as well, of which the AFREhealth-CUGH is one working group, and there are a couple of others. The Global Health Humanities Working Group that I chair and I'm very excited about as well. A very active component of the CUGH is currently chaired by Tracy Raven and James Hudspeth, and formerly by me. It's the Education Committee with a lot of subcommittees that some of you have sat on. And I know Elsie was on the Capacity Building Subcommittee, and many of you were on other subcommittees. There's Educational Product Subcommittee, Competency Subcommittee, the Advisory Service Subcommittee, Workforce, Undergraduate and Masters Subcommittee, Training Advisory, and then at various points task forces are appointed, such as for the abstract review and conference planning. So we have a very, very active committee structure at CUGH. We have elections for each committee, and it's often quite competitive to get onto the committees, 20 members per committee, quite a sizable structure. How the AFREhealth-CUGH working group was formed, just briefly, was in 2017, following the second AFREhealth meeting in Accra. The idea was proposed, and we had lots of conference calls, and Elsie was on those, and Abigail and Mariki de Villiers. It was followed up at the CUGH meeting in 2018 in New York, where we proposed 3 subcommittees and other areas for collaboration. We had follow-up meetings in Durban in 2018-19. 2020 was a gap year, so not much happened there, and here we are in 2021. And hopefully we'll have a meeting in Zimbabwe next year. We had tried initially, some of you have seen these slides, to map all the twigs, because as we all know, AFREhealth grew out of MEPI and NEPI. And MEPI had these particular working groups, and CUGH had a lot of committees. And initially we were trying to see how we could bring these 2 groups together. Got a bit complicated, and in the end we decided to have 3 working groups, subcommittees, one for education, for healthcare strengthening, one for research, and one for student exchanges. And that is a photo at the 2019 meeting in Chicago of us, and we started having these subcommittees meet separately. It was a little bit compromised in the last year with the COVID pandemic, how regularly those groups could meet. But here they are, basically the three groups that we have, and each of them will have a session today, and hopefully there'll be some discussion in each of them and decide on our path forward, especially as we hopefully come out of the pandemic. So that just provides a very brief context for how we got to where we are, what CUGH is about, how we partnered with AFREhealth. Very exciting partnership. We hope we can keep building on it. And I will hand over to Elsie now to proceed with the agenda. If you have any questions, here's my contact information. Thanks very much, Elsie.
Thank you, Quinton. That was a good summary, and that's where we are. And COVID continues, but we have promised ourselves to continue work. We cannot have too many gap years, otherwise we will not move forward. So moving on, it's really a great pleasure for me to welcome Dr. Jim Campbell, who has graciously agreed almost at the last minute to be our keynote speaker. Thank you very much, Dr. Campbell, for agreeing to share with us on a very important topic. I will introduce you. Dr. Jim Campbell is the Director, Health Workforce.
Elsie, you're muted. You're muted, Elsie. You need to unmute. Elsie, you're muted.
I'm very sorry. Very sorry, I was mute. Okay, now I have to go back, and I've wasted a bit of time. I'm sorry about that. So we have the pleasure this evening to welcome our keynote speaker, Dr. Jim Campbell. Thank you so much for agreeing almost at the last minute to be our keynote speaker on such an important topic. Thank you very much. I'll just introduce you. Dr. Jim Campbell is the Director, Health Workforce Department at the World Health Organization. He oversees the development and implementation of global public goods, evidence and tools to generate investments in the education sector, in employment, retention of the health and care workforce in pursuit of global health security, universal health coverage, and sustainable development goals. His present portfolio includes the short and long-term impact of COVID-19 on the health and care workforce, oversight of 2021 as WHO's International Year of Health and Care Workers, and implementation of the WHO's Global Strategy on Human Resources for Health Workforce 2030. So over to you, Dr. Campbell, to give us your keynote address. Thank you very much.
Thank you very much, Elsie. Good afternoon, good morning, good evening to colleagues who are joining on this final session of your annual event. My appreciation to Professor Abigail Kansembe, Professor Quentin Eichbaum for their introductory remarks and the continuing partnership between AFREhealth and CUGH. It's good to see a few names on the participants there who've been long-term colleagues and collaborators, and a few new friends as well. So I was asked to give you a perspective of the impact of COVID-19 on the workforce, and in particular in the linkage to the sort of global health workforce crisis. And I've tried as best as possible to really put that into the context of the African region, to actually sort of give you some thoughts and provoke any question, answer, and discussion. So with no hesitation, let me share my screen and give you the opportunity to to the presentation. Okay, so the global workforce crisis, what do we really mean by this crisis around the world? We have in WHO really looked at this from the perspective of two markets, the education market and the labor market. And then really looking at the consideration between the need versus the supply from our education market, the economic demand, the capacity to create jobs, and the distribution of the workforce. And I know that in your conference this year, you've been particularly looking at equity, social justice, and social accountability, and how that has an impact on distribution and equity. And it's part and parcel of our logic as well. We see that in the African region, based on the analysis we did for the Sustainable Development Goal period, 2016 to 2030, that at the early stages of that, we were looking at a shortage in terms of meeting essential services needs, the ambition for universal health of approximately 6 million workers for health and care services. And so that's perhaps the largest share by region around the world in terms of the global shortage was to be identified in Africa. What happens when we have supply-demand mismatch is some of the challenges that we're seeing within this crisis. We are aware of education services, education sector really trying to increase the number of graduates, both the quality, their skills, their competencies, their engagement in terms of meeting the needs of the populations they will serve, but being unfortunately not always correlated with increases in the ability of governments to employ graduates. And so we're seeing that most recently, just in the last few months, some examples here in Ghana, in Nigeria, and just another slide in a moment on Kenya, we're seeing the unmet need for service delivery coexisting alongside graduates who are unemployed. And this then often gives rise to continuing increases in labor mobility and migration, both within a country, within a jurisdiction, in terms of migrating into other opportunities, other careers, other private services, private sector services, but also intra-regional migration. And within the African continent, we're seeing that this is rapidly increasing, but also to opportunities in upper middle income and high income countries. And we've seen in the last decade a 60% rise in migration of physicians and nurses to OECD countries. And in the State of the World's Nursing report that we published last year, we identified from data coming from 194 member state countries that consolidated the aggregate numbers. We were looking at nearly 1 in 8 nurses practice in a country outside where they were initially graduated and potentially licensed. So this is really driving some of our challenges, not all of them, but it is a key element of it. And like I said, the news that we've seen coming out of Kenya just in the last 3 days that you've been hosting your annual conference is that we're seeing new arrangements being put in place for the mass migration of Kenyan nurses to the United Kingdom. At the same time that Kenya reaching the ambitions of the SDGs, density of occupations, which is still considerably lower than the WHO guidance, and yet unemployment coexisting at the same time. Obviously, there are benefits to migration, and it's a complex issue, but nonetheless, when you see this level of unemployment and this level of outward migration, when the continent still has pressing healthcare needs, not only the essential services that we have to do, but the management of the COVID-19 pandemic and the management of implementing the world's largest ever vaccination program that we've ever known. It is nonetheless something that we should all be watching and following with interest. Again, to try and sort of give a perspective on the African region here. Last year, the World Health Assembly, member states asked us to update the list of countries that were considered to be facing a critical shortage of healthcare workers. And the work that was completed in a publication in February of this year, and that's prior to the pandemic and the impact on infections, deaths, and continuing migration. So based on data prior to the pandemic, 47 countries were identified as still having critical shortages, and 33 of those 47 were in the African region. So it continues to be, despite the work that we was identified in MEPI and the nursing program that you would all be familiar with, despite the work of the transformative education work that was conducted by WHO more than 10 years ago, we're still seeing a continuing mismatch between education and employment in health and care services across the continent. So that's the crisis that we're faced with. What's the impact of COVID? So that's the first column here on the left-hand side in green, really to sort of demonstrate before COVID-19, there were already key considerations about services being understaffed, public services being understaffed. What we've seen then is the next column along the COVID-19 immediate response. Immediate redeployment of that workforce to go into the COVID-19 services. Infections and deaths of health and care workers in the early period of 2020, particularly high, and taking people out of their work practice environment. An absence of protective personal equipment, which meant that people were unable to staff services. What we're now seeing, 20 months on, an additional burden of the COVID-19 response, the stress, the anxiety, the increased absences from work being added to a redeployment of personnel to go into vaccination services. We're very encouraged to see that the COVAX facility in the final quarter of 2021 is likely to see a 15-fold increase of distribution of vaccine products to the 92 countries that benefit from that initiative, which is a fantastic surge that we will see. But at the same time, that's going to put additional burden on a workforce that's maybe dealing with the third wave, a fourth wave, and are already exhausted. So really, our choices do count, and our policy decisions have a major impact. Workforce shortages, as we've just discussed, and these columns and challenges, in a survey of member states earlier this year to look at the impact on essential health services, 2/3 of countries identified insufficient staff availability as the most common cause of disruption to health services. So people are, whether that's in sexual and reproductive health, non-communicable diseases, neglected tropical diseases, HIV services, TB, malaria, the most common cause of disruption is the absence and lack of healthcare workers. And this should come as no surprise, but it demonstrates that the pandemic has really exacerbated the earlier shortages. We have at WHO put in place a standardized measurement and reporting framework of the impact of COVID-19 on health and care workers, and looking at various domains. The health of health and care workers, obviously, which the infections and deaths have taken clear things, but also the mental health impacts, the working conditions, the availability and distribution, and just a few, a few high-level numbers here. In 2020, we had over 80 reported instances of labor disputes and strikes. That is a 10-fold increase than any other highest number of incidents previously, just demonstrating that our workers and their unions and associations very frustrated with their working conditions, the PPE and many other issues. Rarely was this over pay, those protests and disputes. It was over the practice environment, the safety, the risks of being exposed in their settings. We've seen high levels of depression, anxiety, and insomnia, and burnout and stress. We've also unfortunately seen applause and appreciation turn into attacks, bullying, and discrimination. So really very concerning when we look at the increased workload that we will be facing to understand the working conditions of it. Infections and deaths, we continue to follow the infection reporting of all numbers and the deaths of all numbers, but we're trying to disaggregate continuously by occupation. And everyone who's involved in surveillance and critical reporting systems will know that assessing morbidity and mortality by occupations is a challenge that has been with us for decades and decades. It's no different for COVID-19, but of the data that we have, where we do get occupations in about 1 in 5 incidents, we are able to track the trends in health worker infections and deaths. Encouragingly, infections have come down from the first 3 to 6 month period, so that the relative risk of infection amongst healthcare professionals, especially as vaccination has been an additional tool to be added, but also with PPE, with clinical governance and risk protocols, has come down to about equal to that of the general population. And many instances of infection now are coming from community spread rather than through occupational infections. But nonetheless, they're still too high. And we estimate that, unfortunately, we have lost to COVID-19 more than 115,000 health and care workers since the start of the pandemic. Not only that, but the infections has an impact on cost, and treatment has an impact on productivity. And so the burden of infections beyond those individual and the family and the carers and our colleagues that we have lost is still nonetheless of significance to the overall healthcare system. Our education and employment costs to build capacity and knowledge really being ripped into the realities today. Mentioned earlier that the vaccination program that we are looking at worldwide, largest ever, that we would have to understand. And we were looking at the modeling and the options, what would be needed around the world to look at 20% global vaccination targets. The target now for 2022 is that we have, by June of next year, that we have 70% of the world vaccinated. So this, you can see, is an underestimate of what we need in the next 12 months. But we enter the experience of the vaccination to date tells us that we need vaccination teams that are able to be working throughout the period as supplies become available. And that's an additional labor requirement of over 1 million workers in those vaccination teams. That's the vaccinators and the supervisors, but all the support staff that go with it as well. And not every country has the ability to be able to accommodate that surge capacity with their existing workforce. We've seen that around the world. Many have gone to recruiting from all different options. I just wonder if I'm getting a bit of echo. I just wonder if people could mute when they're not.
Yes, there's an echo. Please, could you mute? All of you except the speaker.
And this is really then. Sorry, that echo is becoming.
It's becoming worse. What's happening?
We can see who's not muted. Priska Kayo, we can call them out, or you can centrally. Quite a few unmuted people.
Clara, could you please mute them?
Let's try again.
Okay.
Oh, that seems to have been. So thank you, colleagues, for participants for muting when you went there. So indeed, this is an element that we're concerned with, that we do need to be looking at the rapid recruitment, education, support, and supervision of vaccination teams, and not expecting that this burden will fall upon only the existing health workers or on volunteers and others in every one of the countries where we're seeing. All of the work we've been doing on the standardized measurement reporting, living systematic reviews, the data that we're getting and the triangulation of that data is informing a series of the interim guidance that we have on health workforce policy and management in the context of COVID-19. And that's last version was published in December of last year, and we'll be doing an update and refresh of some of those key things. Encouragingly, and this is testament to the dedication and sacrifice of millions of workers worldwide, there is rapid adaptation and adoption of evidence-based practice. We've seen across the world countries get to grips with the disease and the evidence and the clinical protocols on this. And we're seeing that the public health and safety measures really coming into place. We know, and with CUGH and AFREhealth, we know that evidence-based practice and implementation is having an impact, and we need to put that into our education, we need to put that into our training, and we need to ensure that we're getting that through every opportunity of learning in practice. On that evidence is also then informing a global policy discussion and global discourse around this issue. We had 2 agenda items at the World Health Assembly in May and June of this year on the workforce. Both of those discussions heavily influenced by COVID-19. And we saw then that whilst the discussions were around looking at the opportunities for employment and nursing and midwifery, the resolution that member states passed, led by Ethiopia and Senegal, and with every country in the African region co-sponsoring this resolution. And these are a show of the African solidarity and support to the language in this resolution. The language is on protecting, safeguarding, and investing in the health and care workforce to ensure that we protect those who have been protecting us. And this is language really, again, then that it comes back to the whole issue, as I spoke about right at the start here, about the education market and the labor market. We need to generate the necessary investment in education and jobs. If we don't, despite the evidence for the last 10, 15, 20 years, if we don't get the investment into education and jobs, we're going to continue to have shortages around the world, but particularly across the African continent. That education and jobs is not necessarily educating more of exactly the same, but it's looking at what are the future needs of populations, what are the competencies and skills of our graduates that will be needed, how will they be flexible and committed to lifelong learning and adaptable to any scenario that they will face, and then ensuring that our education systems react to that and become 21st century education systems. Similarly, this investment theme runs throughout the International Year of Health and Care Workers, which was proposed at the Assembly in 2020, recognizing the contribution, dedication, and sacrifice of health and care workers around the world at the forefront of the COVID pandemic, particularly to recognize and commemorate those who've lost their lives, to prioritize them for further protection with the vaccine, and then to mobilize commitments to protect them in future and invest in them in future. That same commitment again echoed across the African continent in June of this year, and the United Nations General Assembly, a statement led by African countries came out exactly as you say, that we have to protect those who protected us. We have to ensure that our health, the investments necessary to continue to work towards the delivery of universal health coverage, global health security, and elsewhere. So this evidence-based guidance from the impact of COVID-19 informing global discourses in Geneva, in New York, and across the African continent. Similarly, the evidence that was published in The Lancet in June of this year, which was the review of the African pandemic responses, and of which the evidence had been, inter-action reviews had been completed by 18 of the African member states, and a review of the information from countries, the information from governments on what the challenges are, what the success and what the future needs. And if you read this document and look at this, it is very sobering to look at the challenges again. We continue to talk about the challenges where we haven't taken the appropriate action to address them. When our labor market and our education market are not generating the capacity that's needed to have primary healthcare services, public health services, emergency preparedness and response. A shortage of personal protective equipment throughout, and a bit of time, some delays in ensuring that evidence-based practice was put in to reduce risk and bring down infections. But nonetheless, you know, the effort of and the dedication of workers really coming through, learning from all their skills that they'd had in immunization, in polio, in pandemic influenza, really being redeployed rapidly, a commitment then to really apply surveillance tools and clinical protocols, improvements in community case management, therefore keeping people out of hospital. But a concern still coming through about the stress. These are people at the end of the day in harm's way, and they are 20 months into this global pandemic. Humans doing extraordinary work under extraordinary circumstances, but nonetheless fatigued by the continuing pressure. And the education element continues to come through the thing. They are some of the perspectives that I wanted to bring to your discussion today. I'd also like to just end on an invitation to AFREhealth and CUGH. Part of the evidence that we've identified is clearly that we need again to revisit what is the global evidence necessary to make changes to education, to take opportunities that may come from the COVID impact on digitization, digital health, digital education, digital tools in the scale up of education and employment. And we will be extending an invitation to you both to join WHO in consolidating new evidence and new guidance that really comes in to work with us in 2022 on this, because I think there is a huge opportunity to look at the legacy of COVID-19 and ensuring that is put to most optimum use in terms of the ambitions for the Sustainable Development Goals. Elsie, thank you very much for the invitation. And I hope amongst today's group. Thank you very much.
Thank you very much, Jim, for that presentation. It really highlights the global and then comes down to the local for us in Africa, what the real issues are with the health workforce, especially during this pandemic. And it's actually very saddening. Like in Uganda, we have only six neurosurgeons, and one of them died due to COVID. So that really hit us all so much. Of course, we've lost so many other health workers, but that really brought to the fore what is happening nearly everywhere. And thank you for all that you've put together and shared with us. We have about maybe 5 minutes if there are any questions. And I think Quinton has a question. I will allow two questions, then we continue. Okay. Yes.
Thank you for the great presentation. I had a question in the beginning, and I missed this in the news, the providing of employment to, I don't know how many it was, thousands of healthcare workers in Kenya and the UK. I wonder if you could elaborate a little bit on what underlay that negotiation and what it entails. If there are any, there's been an ongoing discussion about compensation for countries where they take healthcare workers from Africa. On the one hand, these were provided employment. Are there any plans for these workers to return at any point, or is it just an employment opportunity and that's the end of it? Francis Omazwe gave a talk in an earlier session talking about the World Health Assembly negotiations, and I'm not sure where that all stands, but I'm curious if you could answer that.
Thanks, Quentin. Yes, indeed, this is news that coincides with President Kenyatta's visit to the United Kingdom, but obviously there's been preparation in terms of making that announcement. It's part of a broader collaboration. There will be a Kenya-UK Health Alliance. It will be bidirectional. There's going to be a major investment in Cambridge University, and I see Peter's on the call and others who've worked with Cambridge for decades. That's in particularly going to be supporting the next generation of clinical research around COVID-19 and genetic sequencing and things. So it's going to build capacity in Africa. There is an intention that this will be temporary migration opportunities and that the people will return. The UK themselves have identified, published in February, a new guideline on ethical migration. But at the same time, the UK is one of those OECD countries that is, with COVID-19, they have, health workforce shortages, over 100,000 shortages in the UK, jobs. and infections and deaths and absence from work, and a vaccination program which has been recruiting over 70,000 people. So they are in the market for graduates, and so that's coming through. Quentin, we could talk forever on this issue. We are concerned at WHO. We identified, as part of our evidence review, over 80 countries have made adjustments to their regulation to make it easier to recruit, license, and enable to practice foreign-born, foreign-trained health workers. Made it easier. And there are even some countries that will pay your flight tickets, your accommodation, and give you a signing-on bonus to migrate. We are very concerned about the impact of this on African healthcare systems in post-COVID-19 into 23, 24, 25. Over.
Thank you. Huge issue. Thank you.
Okay. Thank you very much. There's one question. It says, historically, times of profound challenges result in tectonic shifts and open opportunities for major changes. What are the top 2-3 opportunities that you see for radical positive change to meet the needs you have summarized? From Judith.
Indeed, I think there's increased awareness that one of the major changes that will come will be through digitization, digital tools that we can provide greater opportunities through that. But there's an equity issue there that's still got to be resolved. I think we're going to see the world's largest expansion of technology transfer in the medical supply chain, which will come through, and that will create, that's a human development, human capacity change that we'll see through. Within the workforce elements, I think we're going to see greater recognition of the value of people that are close to the community for surveillance systems and health security and preparedness. We will see the professionalization of occupations that are tended to be grouped as community health workers rather than the volunteer type approach. But when I think on education, this is when the invitation was to you. I think one of the opportunities is we have to convene as a global scientists and actually say what is the opportunity in education and employment that we come through, and how do we put that evidence on the table? I think there's a global willingness to do that, which was not there before COVID-19. Over.
Thank you. Just one last one. I can't leave it from Michelle Berry. How are vaccinators being mobilized to Africa? Is there money from COVAX being directed to that?
So there is an opportunity here. I mean, every country has done their national vaccine and deployment plan. They've looked at what their vaccination team requirements will be as doses are distributed, what their supply chain challenge will be. The ACT Accelerator is not included in its budgetary needs the cost of that labor, because obviously the cost of some of the medicines, the diagnostics, the oxygen is still a priority in getting the supply chain going. But the World Bank, the African Development Bank, many other multilateral development banks have indicated, and the International Monetary Fund have indicated, that they will provide governments with access to capital. And with global interest rate time, it's almost at 0% interest. You can put injections into the labor cost that will be necessary for it. So it is an opportunity for governments and stakeholders in every country to argue for long-term sustainable financing to go into education and employment, into human capital. It would be almost negligent of the medical community, the nursing community, the professional occupations, if we allow this money only to go into vertical immunization type initiatives. and not have it go into education, employment, and system strengthening. I appeal to all of you to really make sure that in your national dialogues, that any opportunity to invest in the COVID and the recovery goes into education and jobs. Thank you.
Thank you very much. You giving us your time this evening or morning or afternoon for some people. We've taken on that call at least to AFREhealth, and I'm sure CUGH as well. And we'll be joining you on the digital issues concerning education. Thank you very much. So we go on to our next item on the agenda, which is we are going to have a short roundtable discussion from the chairs of the different groups in our working group. We have research. John Nashega will give you 5 minutes to just give us a summary about your working group, because people would like to know. We are going to have to break into groups after this, but for those who are joining us for the first time, would like to give you a flavor of what each group does. We'll begin with John Nashega for the research group. John, are you there? I saw you earlier.
Hi, can you hear me?
Yes, please, go ahead.
Okay, I'm gonna share my slide, just a second. Can you see my slide?
Yes, you have 5 minutes.
Yes, yes. So I just wanted to just give a quick overview. Most of our activity were dominated by the multi-country research collaboration that some of the CUGH members are involved. I will cite, for example, Richard Eckenbo and Peter Kilmax and Judy Wasserheit. I did present the pediatric study at a plenary AFREhealth-Symposium, so I'm gonna focus mostly on pregnancy study. Just a few highlights in 5 minutes. As you know, this collaboration started from our early work in DRC, where we found that very shockingly that children under 20 years had a hazard of death, which was unacceptably high, but this was a cohort of 800 patients, which included only 34 children and only 12 pregnant. So it was a bit difficult to conclude, have conclusive remark about just that small number. So it did trigger us under AFREhealth and CUGH discussion to design multi-country study to pull data, so to have more power. And so 2 opinion paper for calling for data for pregnant and adolescent were published. And so about pregnancy, there was no much data out there published, at least on the African continent. Most were from Europe or other country. Only recently, a paper by Villar in JAMA Pediatric multi-country prospective cohort, which only included, was still not much African data in that very well conducted study, or just 2 countries from Africa and from the West, I think Ghana and Nigeria. But so far, most of the data show that high mobility and mortality in pregnant women with COVID compared to those without COVID. So we thought it was important for us to look into this, especially in the context of Africa with high comorbidity, both communicable and non-communicable, which can impact outcome. So our study design obviously was retrospective cohort analysis, but the advantage is we have 2 control group, I think important, both a group of pregnant women who are COVID negative, but also a group of women who are not pregnant, but who are COVID. So we can look at the dual effect of pregnancy on COVID, but also on COVID on pregnancy. And I think the Villa study published in JAMA Pediatric did not have 2 control groups, they only have 1. So this is the country involved. Again, I highlight that this was really leveraging the MEPI-NEPI collaboration on the continent. And it was very rewarding and with relatively, with some funding from Fogarty. So just a quick result on this paper, which was submitted to the Lancet Global Health and which is under major revision. So we've been able to include about 740 women, 355 pregnant and about 300 non-pregnant with COVID positive and 92 pregnant COVID negative. So among women with COVID pregnant compared to non-pregnant patients had increased risk of ICU admission and also oxygen supplementation, but also we did not find a significant effect on mortality, but the adjusted relative risk was higher. So this is just give you a quick overview, as you can see, of those outcome, quite clear picture. What the last one of my last slide is just also important finding we had is thromboembolic event was quite more frequent, more COVID positive compared to COVID negative pregnant women, and also C-section quite more frequent. And in terms of neonatal outcomes, so there was more trend for preterm infant in COVID positive compared to negative. So we concluded that this is a population, as the Delta variant are really ravaging the world. I think, and the vaccine is under rollout, but not yet in Africa. I think this is really a risk population where we need really to pay much attention as those vaccines become more available. So just also to mention, we lost one of our biostatisticians in this project, Prof. Birano Ayele, from originally from Ethiopia, was based at Stellenbosch, was our data coordinating center director. And I would like just again to acknowledge the support from Fogarty, all the PI on those 6 countries, Nadia, the Kawisa PI, also Lynn Moffenson from EBGAF, who've been very active, and also our biostatistician, Machekano, who replaced Birano at his passing. Thank you very much.
Thank you very much, John. We appreciate the work of the research committee. Let us have Faith Nawaji tell us about student exchanges or student affairs, just briefly, before we go out to the breakout groups.
Sure, thank you so much, Dr. Elsie, and to all our attendees from our former AFREhealth CUGH satellite that we held in April. Hopefully I'm remembering well. We really developed an agenda to move forward to develop an AFREhealth student community, so that way we link them up with TAC, which is the CUGH student community, to foster engagement and learning of the various future health workforce in both organizations. I would like to report that we were successful. We now have an interim committee that has been created to craft the whole organogram of how it will run, and then we'll be able to communicate when it's launched. And this is work that we've done as GMX in partnership with the AFREhealth Student Advisory Committee. So that's all I have to say, and thank you.
Thank you very much, Faith. That is very important for AFREhealth, because the students are our future, so we should make sure that they are involved in our affairs if we want AFREhealth to go on beyond us. Thank you. So Judy, please, Judy Hanyola, please tell us about the education.
Thank you. The education committee, in the same vein, in the same light with what Faith has said, following the CUGH satellite that we had in March earlier on this year, we came up with two areas of focus that seem to be what everybody wants. And the first one was interprofessional education. I talked about this earlier in the satellite that preceded these ones, where we're really looking at embedding IPE into our education systems within Africa, wherever they may be, and really moving forward the needle for IPE. It was very heartening to hear Jim Campbell. In fact, when I listened to him, the sense I took away is how important nursing is. As a nurse myself, it's amazing to see the importance that is given to nurses at a time like this pandemic, where we begin to realize the frontline and the bedrock of our health systems actually really rests on frontline workers such as nurses, such as community health workers. And often these are the people who are forgotten and who are sometimes taken for granted. So I think for me, when I look at interprofessional education, we need to bridge that shortage that Jim is talking about and that WHO keeps bringing to our, to the front of our minds, can only be bridged through interprofessional education. Else, you mentioned you lost one of only 6 neurosurgeons in Uganda. The death of that gentleman, it will be nigh impossible to fill that gap in the next 2 years when we want to vaccinate 60%, 70% of our populations. And so for me, I think IPE is one of the quickest methods we can begin to look at critically to begin to answer these questions that even Judy Wasserheit is saying, the tectonic plate shifts that are happening. So that's just my, beating the drum for interprofessional education. At AFREhealth, we have an IPE TWG that I chair, and then together with Quentin under the education subcommittee, we are looking at IPE. The second prong we looked at within education is virtual learning. So we had the opportunity and the privilege to hear from platform one from Finland, which was looking at a way for digital learning. We had a gentleman from Scholar RX and a gentleman from Lecturio. Some of you have heard about some of these digital learning platforms. And now with COVID and first, second, third wave, we know that more than ever, we are going to really be locked into our homes or not being able to meet physically as we would like. So virtual learning is the way to go. So for me, just to give that summary, IPE and virtual learning platforms are the two-pronged focus that the education subcommittee of AFREhealth CW more about this when we come into our break. Thank you, colleagues.
Okay. Thank you, Judy, and thank you all the chairs of the committees for the hard work. We have very little time for breakaway, but I'm going to give the microphone to the virtual microphone to Georgina Eboa, who is our executive director at AFREhealth, to lead us through this for 20 minutes and also the report back when we get back.
Thank you very much,
you.
Elsie, and thank you very much, committee chairs. So as we move to the groups, we're giving you 10 minutes, because looking at the time, yes, we have to use 10 minutes because we've really been through a whole long day from FEMA to here. It's been a long day. So 10 minutes, please let people understand what your committees do and how they can become members. Yes, that is what you're supposed to do. So who is our IT person, the moderator? Please to group us into 3 so that we can really learn what specifically those committees do and how we can really join them. Thank you very much. So we come back in 10 minutes. Yes, please, Clara, yes, group us immediately, 10 minutes. The student exchange. They were the first to come here, though the time wasn't up. So let me give them the opportunity to report on what transpired there.
All
3
right.
minutes for each of the groups.
All right. Thank you so much.
All right. Thank you.
Thank you so much, Georgina, and to the entire team. Our group really was really brief on what we discussed. We understood an opportunity to really strengthen our ability to share resources, and we would like to explore more what Lecturio is all about and see how that can be leveraged between both CUGH and AFREhealth to foster learning and all that. We had a student who attended, and we attended we encouraged them to look out for the website and also be part of our mailing list so that we can be able to give them updates and all that. So the AFREhealth Student Committee will be made to be functional by the end of this year, so that next year they'll be able to be linked with TAC, CUGH, and that momentum continues. So that's all we did, and thank you so much.
Thank you very much, Faith, and your group. I think, Judy, you are ready, I can see, so let's hear from you.
Thank you, Georgina. We didn't have much time, but in the short time that we had, we seem to have an agreement on there are many players in the space of interprofessional or education first and foremost. And so then was narrowing it down to IPE. We are looking at AFREPEN working in that space. And so the consensus is, can we understand better what AFREPEN does? And then through, by mobilizing resources from CUGH through AFREhealth, we can perhaps have a tangible output or deliverable within this ACWG. So that's what was discussed. I think my take home is that IPE is really the way to go. Everybody, I think every normal person agrees that this is important. So I think in summary, we will now in our next education subcommittee meeting agree on the key deliverable, whether it's by December 2021 or by first quarter of next year, whatever timeline we give ourselves. What's the key thing in IPE that we would like to do? I think more than anything, Georgina and all of us here, this session is sort of bringing to me that all of us are passionate and keen to support initiatives. All of us are, have the fire burning to drive things forward. And so for me, I think the work cut out is then how do we do this? And I hear from CUGH, they are very keen to support AFREhealth. AFREhealth is providing the people coming together. And so for me, that's a very good way forward. So that's brief summary from our discussions, Georgina.
Thank you very much, Judy. Then I hope that the webinar that we talked about this morning, we can bring the committee along. The fire is burning. We can't wait till December. So September, October, otherwise the fire will die out. So let's see how we work together.
Yes, sir. Yes,
really
sir.
have that. Thank you very much, Judy and your group. Can we hear from Jean, the research group?
Yes, sure. So we did not have much time, but we discussed basically new ongoing area of collaboration, including the new initiative of scientific mentoring webinar that AFREhealth did launch very successfully, which connect about on average between 200 and 300 young investigators on the continent. And also grant writing webinar. The last one was with EDCTP, was also attended almost by 250 member. But beyond that, so we Peter Kilmax from Fogarty discuss also the CUGH conference 2021, the abstract advising program, where we invite member to join as advisor or advisee. So they need to sign up. So AFREhealth did dispatch those information. So we encourage people to participate, both established and young investigator. We also discuss new opportunities. So we had the honor to have Prof. Etienne Saguet from University of Jos also give new idea of collaboration, including access to literature, or access to literature, scientific literature. And there was a suggestion that this proposal will be taken back to the CUGH committee to look at how to work this out. So we did not have much time, but we were pleased also to see new member joining the call, and they introduced themselves. And I'm sure as we move forward, this group will go from strength to strength and deliver more. Thank you.
Thank you very much, Jean. I think Peter has put the link for signing up for the abstract review on in the chat box, so we can look at the chat box and then we see. But since we have members' email addresses and other non-members, we also share with them so that they can also sign up for that. Thank you very much.
Give me a second. I just want to chime in and say that AFREPEN is having its 3rd annual conference in September. I'm also just, if you're interested in seeing and hearing more of what AFREPEN is doing in IPE as we have been talking, go to www.afrepen.org and please be part of these discussions as well. Thank you.
Thank you very much. For those of you who are not members of AFREhealth, remember to join www.afrehealth.org and become a member so that you can really enjoy all the benefits that we are enjoying. Over to you, Quentin and Elsie, as we close this session. Thank you very much.
Quentin, you go first.
Oh, so I'm not sure why we cut the discussions a bit short, because we still have a lot of time left. So maybe there's be that as it may. This is a group that was formed years ago, as I said in the beginning, joint at an AFREhealth meeting and then a CUGH meeting. It's progressed. We haven't always been able to meet as regularly as we'd wanted to, but the groups should make every effort to meet, and I think progress has certainly been made on all fronts. The student exchange group has made progress. The research group has set up a very viable mentoring program. The education group has done a lot of exploration with virtual learning platforms that we intend to pursue. We've had independent discussions with some of the developers of the platforms, and we want to go ahead with that. There's some things we need to iron out a bit between how the interprofessional education group, of which there's both AFREPEN and groups within AFREhealth, will work with CUGH, but the education committee at CUGH has a lot of resources that can be brought to bear to help with this initiative. We just need to see how to move forward along those lines and get what CUGH has to offer that works best alongside what AFREhealth really needs. And so the aim of that group is to synergize the efforts. I think that Elsie and I have talked about going forward with Abigail, and I think Judy as well, is to have joint meetings of all 3 committees every 2 months. And I think that will help as well. Perhaps the subcommittee's been working a little bit too much in isolation, and it will help us to see how to communicate between the 3 subcommittees. Everyone has a lot of work both within their respective organizations, so we don't want to make it too onerous for everyone, but we are partners in this venture, and I think we are very complementary in many ways. We have an article that's coming out in the Annals of Global Health describing the previous satellite and what North-South partnerships should be about, what some of their deficiencies and strengths are. So look out for that publication. I'm also very excited about the AFREhealth book that's being produced, and Keith Martin and I contributed a chapter to that on North-South partnerships. So that's something we should look at very carefully. I think what we all need to be very cognizant of as well is the whole, and I hate to call it a movement, but the rethinking of colonization and decolonization and how we do that. At some level, it's become a buzzword, and it needs to be thought out very carefully and how we do this. Put that in some level on its agenda as well. What do we mean by decolonization? What are partnerships really about, and how do we have more equitable partnerships, which is a theme of this conference, between North and South partners? I think we have been doing it, not quite right. I think the texture of global health, as it is understood in the global North, is going to change, and the way the pandemic has had a big influence on that. But to my mind, the notion of thousands of North Americans descending on Africa for global health experiences will have to be rethought in a judicious and in a very thoughtful kind of manner, what we're actually doing and with all of that. So I think there are a lot of movements. These are at once exciting and somewhat depressing times, but we'll get through this as partners, and I think we should strengthen this partnership at every single level that we can. There may be other groupings that the ACWG wants to think about, but we'll explore those at our joint conferences. And I'd like to conclude that it's been a great pleasure working with colleagues at AFREhealth. They're always so collegial, and it's a collectivist culture interacting with a highly individualist culture, which has its own problems, but our collectivist cultures think together, pay attention together, and it's something I find very gratifying. So Elsie, thank you so much for putting this together, and I'll hand it back to you.
Thank you very much, Quentin. Mine is a simple job now. We are coming to the closure of this satellite. I'd like to thank you all very much for attending. I'd like to thank Dr. Jim Campbell very much for his keynote address. It was very insightful, and it called upon both CUGH and AFREhealth to do something about virtual learning. And I think we should take it up, and the Education Committee is already planning to do something about that. And already things are happening on both sides, especially during this COVID-19 pandemic. I would also like to thank the chairs of the different small committees for their commitment, Judy, John, and Faith. Thank you so much for keeping the committees moving, and we know that you'll continue working on making sure that we meet more often. I would also like to thank Quentin for representing CUGH on this group and actively working to make sure that this group continues. We really appreciate the collaboration between CUGH and AFREhealth. And ever since AFREhealth started, CUGH has been very helpful in helping us set up systems, and also as they had been in this for longer, so they've been very, very helpful in holding our hands. So we appreciate that, and the collaboration is really good, and we participate in the CUGH conferences, and you people also participating in our conferences. We see that as very helpful and useful. As Quentin said, moving forward, we are going to try to meet bi-monthly, and we'll give you a date. We said the next meeting Quentin, do you remember the date now? It's kind of my, but it's
I think it was the end of August, beginning of September, but
September. Anyway, we'll
were
send
trying
out the date.
to, we're trying to find out a set time possibly to meet, but that may not be easy. Bi-monthly.
Okay. And then we will obviously participate in the CUGH conference like we've normally done. And I would like to thank you all for coming. I know this is the last session. For some of us, it's actually coming to tonight. It would have been dinner time. So, and for those who woke up very early to join us, we thank you very much. And we know that we'll continue to meet. So thank you so much, and have a good day wherever you are. And maybe Georgina, a closing word, and then we close.
Right. Thank you once again, everyone. This brings us to the end of the entire end of year activity. That's the annual activity, end of our annual activities that we do. So we started with the GC meeting, we had our symposium, and then we've had our satellites. It's really been wonderful. We've been getting a lot of messages from people expressing their satisfaction with the way this virtual program has gone on successfully, and we've done all because you were with us. Thank you all, and we wish you all the best. Bye-bye.
Bye.
Enjoy.
Bye. Bye-bye.
Bye, everyone.
Bye. Bye.
Bye.
Bye.
Everyone.
Thank you very much. Goodbye. Have a good weekend.
Yes.
Have a good weekend. Bye-bye, everybody. Thank you.
On